This is Carol, Dr. Carol. Welcome to the January 29th, 2018 practitioner webinar. This week, I've been on the road for 2 weeks, so I don't have like one big case that I treated 2 weeks ago or a week ago or 3 days ago. This is a bunch of little cases and follow-up from a patient that we talked about in July. So these are small miracles. In the case of the July patient, it's a big miracle, and for some of these patients, it was big miracles. They're small miracles for us because from an FSM perspective, they're just not that hard. These are chronic patients that were helped with simple FSM protocols and a correct diagnosis. Simple for FSM, miracles for the patients. That's kind of what we need to remember. I get used to simple miracles. It's like, well, that's just nerve pain, or that's just abdominal adhesions, or that's just whatever. And for us, it's easy. But for the patient, they are miracles. Tight legs. This is a patient that had a 3-year history of bilateral trigger points in the legs. Pain was between a 4 and a 6. And the trigger points in the legs were in the adductors, the quads, the gastrocs with multiple trigger points. It's like, geez, what do you do? He doesn't do a lot of running. It was a she, I think. And the key to this was, she said, so the leg pain was the biggest complaint. Pain level was a 4 to a 6. But she also had neck pain and headaches. That was the key. And just because I always do this, first thing I check is reflexes. So her reflexes, patellar reflexes were very brisk, +3 out of 10, with cross reflexing. And that points us towards the spinal cord. And no surgeries, no, I'm going to try and move this little thing out of my way. Nope, can't do that. I just need this out of the way. All right, hang on. There we go. So the +3 reflexes were a clue that there was something going on with her spinal cord that was affecting her lower extremities. So when it's just lower leg pain, we treat 40 and 10, right? That's pain in the neck and shoulders, arms, legs, back, all of that. This was tightness. So the loss of descending inhibition gives you, tight leg muscles, increases the tone, especially in the adductors, the quads, the gastrocs, and then once the tone is increased, when the patient exercises, muscles get tight with multiple trigger points. So I did 81 and 10 from the neck to the feet. So the patient's complaint was leg pain. The trick is trying to figure out where the leg pain came from. Why are her adductors, quads, and gastrocs so tight? She doesn't exercise that much. She's not doing 100 leg presses a day with 50 pounds or 100 pounds. She's just walking and exercising. 81 and 10 reduced the tone in the leg muscles from neck to feet. And then treating her neck pain was a matter of treating subacute facets and discs. And that took care of her neck pain and her headaches. And then low back to feet was 91, hardening in the fascia and the muscle belly, and then scarring between the nerve and the fascia, low back to feet. So that was an interesting case because it's not exactly what you would think of, right? When you see tight leg muscles, you don't think of the spinal cord. But every time you treat a new patient, and I think this was in a seminar in Cleveland, every time you treat a new patient, you always just want to just check the reflexes, and they were hyperactive. So the hyperactive reflexes give you a clue that aim you towards the spinal cord. So that was fun. There were 2 cases of plantar fasciitis. And I'm not sure I spelled fasciitis right, but that's what spell check says to do, so there we go. We are on, so this first patient basically doesn't walk much. There was no increase in exercise. She just has foot pain, and the bottom of the foot was tender to touch. This patient ended up being basically a 40 and 10 patient. Remember that the pain pathways in the spinal cord have the feet closest to the disc, and the disc is inflammatory. So the pain pathways, the homunculus, the cables that come from the bottom of the feet are up against the disc. The disc is inflammatory. That inflames or irritates that part of the homunculus that relates to the feet. So the patient tells you, I have bilateral plantar fasciitis, but there's no cause that would actually suggest that it is actually the plantar fascia. What she has is pain in the bottom of her feet, which is a different thing. They have to call it something, and so they're going to call it plantar fasciitis, even though what it is really is just pain in the bottom of the feet. So in this patient, we did 40 and 10. Pretty soon the pain in the bottom of the feet was gone. And then we treated the neck to get rid of, so treated subacute disc to deal with why it was the spinal cord was tight. Okay, so this is, it's not always what you think it is. Treating it is easy. Figuring out what you need to treat is sometimes more the problem. Now, the second case was this person runs 3 to 4 times a week. Maybe the shoes might have needed replacing, and there was an increase in miles. So with this patient, it was fairly straightforward. It was really simply a tendinopathy, and that is torn and broken in the tendon, 191, 783 is the periosteum where the tendon attaches, and 77 because the layer below the tendons and actually the whole midfoot section is more 77. It's more really dense connective tissue, torn and broken. And I had to mobilize the forefoot and the midfoot, actually. Calcaneus was all right. And in this patient, it really was the foot. Spinal cord is not an issue. The nerve is not an issue. So one is plantar fasciitis, not plantar fasciitis. One is from the spinal cord. That's the take-home message with this. So when somebody says, is there a protocol for plantar fasciitis? Well, kind of, sort of, yeah. If it's really plantar fasciitis, usually this protocol, torn and broken in the tendon, the periosteum, the connective tissue, maybe the joint capsule does a good job. Inflammation in the periosteum, the tendon, the joint capsule would help. And that's how you treat it when it's totally local. But this case, where what you really need to treat is the spinal cord, that case is a different critter. It's a different process. So just the differential diagnosis is important, and figuring out what it is that's going on, that turns out to be important. So this was a kid. He's 10 years old. He's a friend of the family. And we were out doing sightseeing. And it turns out that he's sitting there limping, and his foot is externally rotated. And he's limping quite significantly. And we're supposed to go sightseeing in Washington, D.C. And it's like, what did you do to your foot? And I said, oh, I hit it on the bedpost about a month ago, and it's been really sore. Now, the mom says the patient's been limping, the ankle's sore, and so I got the kid to lay on the bed and looked at his ankle, and the left Achilles is actually thinner. Right Achilles is, the size of your little finger. Left one is about 3/4 of that size, and it's sore to touch. So my curbside diagnosis is when he hit his foot on the bedpost, he damaged the Achilles tendon and like sort of tore a portion of the Achilles tendon. So what is that? Well, it's torn and broken the Achilles. So we postponed our sightseeing for about an hour, and I put a precision care on him from just above his knee, just below his knee, down to his midfoot, the arch of his foot, and ran just torn and broken in the tendon for about an hour while we talked about this and that, and while he played with his phone. And that was a matter of giving it just time to repair the tendon. Now, then we proceeded to walk for probably 5 hours, sightseeing, doing this and that. And by 7 o'clock that night, he was limping again. The next day, he was limping again. It didn't last because as soon as we fixed it, he tore it again. But the treatment plan, his mom has a custom care, is to program 124 and 191. It's just a tendinopathy. It's just that he damaged the Achilles, and it needs to be repaired in such a way that it has time to repair itself before he goes walking on it again. So that was that one. Achilles tendinopathy is really kind of easy, right? Now, I could add 124 and 783. That might be kind of fun because that's where the Achilles attaches. But because it was a direct blow to the tendon and because the place in the middle of the tendon that was sore was sore, my money's just on it's 191. It's just a tendon. You might want to add 77 just for fun and see what happens. But primarily it looks like 191. So this was a patient I saw at Cleveland Clinic when I was there last week. And she was 39 years old. She had a history of abdominal pain. And I believe her diagnosis was irritable bowel. I don't think it was Crohn's. Might have been Crohn's, but irritable bowel I'm sure of. Crohn's maybe wasn't. Diverticulitis. It was just Crohn's, just abdominal pain. And when I palpated her abdomen, the colon, the descending colon, and the small bowel were both tender to touch. But when I went down to the lower quadrant of the abdomen, it was just really sore. So between the belly button, between the umbilicus and the pubic bone, in the lower left and lower right pelvic bowl, it's quite tender, and you could actually feel, some people will say hallucinate, but I think feel an abdominal cyst and some adhesions from what I assumed were previous abdominal cysts, or ovarian cysts, ovarian cysts. So I asked her, it's like, do you have a history of ovarian cysts? Oh yeah, going back years. And it's like, she's 39, and do you have any ovarian cysts now? Well, yeah, I have them all the time. I have polycystic ovaries, and I got pregnant, and yay, had my kid, but the polycystic ovaries are a thing, and so rather than treat her abdominal pain first, I treated the thing I ran into. It's like, well, I'm not sure I can fix her abdominal pain, but the ovarian cysts are easy. So I ran basically inflammation in the ovary, chronic inflammation in the ovary, 7. I don't know why I put 4 first. So 40 and 284 was 7, the ovary. And then scarring. So once the cysts were down, like literally 40 and 284 ran for, I don't know, 10 minutes, you know, the usual. I had a contact on her low back. She was laying on a wet towel, and I had a washcloth across her abdomen. And inflammation, chronic inflammation in the ovary 7, and the tube was 4. Took all the pain down. You could actually feel the cyst shrink. And the look on her face, this is what I mean by small miracles. For the patient, it was a miracle. For me, it's like, yeah, it's just ovarian cyst. But the patient, I've had these for 20 years. How do you get rid of them in 5 minutes? It's like, well, they're easy. I mean, ovarian cysts are, easy. So I did inflammation, chronic inflammation, and then did scarring between the tube, which is 4, the ovary, which is 7. And then her history was about the gut and abdominal adhesions. And what I found was when I was in the left pelvic brim, where the sigmoid should be, there should be a little bit of density there where you run into the sigmoid. It wasn't there. It was a hole. I mean, it was just like gone. But if you follow the descending colon down, you could find the sigmoid. It was scarred to the ovary and the tube. So I did scarring in the sigmoid, well, 13 and 77 actually, scarring between the sigmoid and the gut wall, scarring between the sigmoid and the ovary, sigmoid and the tube, and then scarring, like once that released, the sigmoid kind of rolled back over where it belonged into the pelvic bowl. And then she had scarring at the rectum, and you kind of had to reach down in the pelvic brim. You'll have to watch the video to see how to do that. But you from the abdominal surface, you sort of aim your palpation deep and aim towards the rectum, and then tease it apart away from the bladder and the uterus and the vagina, actually. And kind of tease that apart, and then scarring between the bladder and the tube, the bladder and the sigmoid, the bladder and the ovary, the uterus 34, and the ovary, the tube, and the sigmoid. And then once all this was loose and her lower abdomen was kind of warm and fuzzy and she was a little bit stoned and she was more or less pain-free, then we went to work on the IBS and the abdominal adhesions, and that was really just 40, 284, and scarring in the small bowel. So 22, and we treated the adhesions in the small intestines. Then what was left was what her original complaint was. She didn't expect us to be able to address the ovarian cysts. That was not what she came in with, because she didn't expect any help with that. Does that make sense? She didn't expect us to be able to do anything with that. So the most amazing thing to her was the ovarian cysts were like, easy. Now, I gave her, suggested to her P5P or activated B6. So people I know with ovarian cysts also and only have trouble with phosphorylating B6. So I gave her P5P, suggested B complex to help her detoxify the ovaries, and that should help the ovarian cysts stay away. And then she has an FSM practitioner locally in Cleveland. Ovarian cysts are just easy. There's no reason for anybody to have ovarian cysts. They're just so far easy. So then we move to the abdominal adhesions, and those likewise are fairly straightforward. Scarring 13 and 77 seems to take care of the adhesion itself and the adhesion between the abdominal wall and the intestinal tissues. And then you still have to treat the adhesions between the intestinal parts, right? So scarring in the small intestine and just sort of wait until that sort of gets smushy. And then the sigmoid, 129, 65 is the descending colon, 27 and 16 are the transverse, 31 is the ascending colon, 3 is the cecum. Now the thing with the cecum is you have to remember that it can get rolled over and adhered, especially when somebody has ovarian cysts that are rupturing. That releases a fluid that has fibrocytes in it. And so the cecum and the descending colon can get adhered to the right ovary. So there should be another line in here that says 7 for the ovary and 4 for the tube. The cecum and the descending colon can get adhered to the ovary and the tube. And that would be treated with 13 as well. So think about the abdomen in 3 dimensions. The cecum, the descending colon, transverse, not so much. Descending, well, ascending colon is 31 and 3. Descending colon is 65, the sigmoid. Think about them all as being ultimately mobile. I had a surgery on a patient, attended a surgery on a patient where the sigmoid was adhered to the bladder and the left ovary and tube. So it was midline. The sigmoid, which should be on the left, down in the pelvic bowl, was midline, just below the umbilicus, because it was adhered and rolled over onto the ovary and the tube. Everything in the intestines can kind of squish around and roll. So when you're treating abdominal adhesions, you need to feel for that tissue and follow the anatomical landmarks with your hand so you can find them and figure out what is glued to what. That makes sense? Right? And then inflammation, chronic inflammation in the fascia, the blood supply, the small bowel, the sigmoid. She had IBS, she truly did. So you would treat the things that you would treat to make the gut less inflammatory and less leaky and less likely to stick. And that would be treating inflammation, chronic inflammation, pus encapsulated, all of that. In her particular case, some problems were, I believe, not so much a problem as the ovarian cysts. They kind of busted apart and made everything glue together. So once we fixed those, then it was a matter of just the intestines, and that was actually fairly easy. Anytime you treat somebody with abdominal adhesions and you're doing this much work, this is about 35 minutes, maybe 45, finished up with the frequency to stop bleeding, 18 and 62. In case I dissolved something that was attached to a little capillary, I would not want that to bleed and increase the pain or cause more adhesions. So you finish up with 18 and 62 and probably 40 and 116. So the patient was totally, like almost disoriented because she was pain-free and her abdomen was so soft. And the amazed part, I actually did 40 and 89 for a little bit to get her midbrain used to the idea that she was out of pain. That makes sense. So 40 and 89 get the central sensitization down. If you're coming to the advanced, I recommend coming to the stop. One of them to run 40 and 89 for central sensitization and 40 and 10. So, when the patient is oriented or amazed or I'm not scared, that kind of thing, that's 40 and 89 is how you get them more accustomed to being, to being pain-free. I just got a little bit of network. So the next page, a couple of weeks have been really fun and interesting. The recurrence of abdominal bloating and pain, abdominal pain on palpation, which made me suspect that she had Achilles in the vagus, and she had a 7 out of 10 headache. So the abdominal pain is like, you know, easy to fix the abdominal bloating and pain and adhesion. To fix them first because they're easy. So when in doubt, the easiest thing first. So abdominal bloating is going to be 40 fermentative toxin, 90 surfactant toxin, or vice versa. I can never remember which is which, but you always run them together. I probably ran pus encapsulated, 64 and 42, 64 and 63. So I ran those two till the bloating was gone, and then treated scarring, 13 and 77, 13 in the small bowel, and scarring in the vagus, 13 and 109. Okay, so this made everything more mobile. Everything was less tender. The bloating was gone, but she had a history of mold exposure. And we were done with it. Her abdominal pain remained. And given that she had a history of mold exposure, decided to try that. So it's not like we know what we're doing, right? So there's no way to know. I'm not going to have her do a urine test, or I don't do muscle testing, and I don't, you know, do any sort of strange diagnostics. So it's just logic. Given the history, she had a history of mold exposure, worth try. So I did 23 mold in the liver. Not so much. Pancreas, much more. Her abdominal pain by then was really, if you felt across, it was all the way across the upper abdomen, right across the track of the pancreas. So I did mold in the liver, mold in the pancreas, mold in the vagus, and that didn't change much, except it took away, actually it did change a lot, made her stoned, like she, well, pretty much couldn't talk. But it took away the tenderness in the whole tail of the pancreas, like all the way across. The upper abdomen just disappeared when we ran mold 23 and the vagus. Okay. Then what was left was over here by the liver, ran 35, not so much again, but dropped down below the liver, and there we were on the bile duct, 21. Mold in the bile duct, mold in the gallbladder, and then mold in the small bowel. This helped the abdominal pain a lot, took the pain down, made her abdomen all squishy. She was all good. So pretty soon her abdominal pain was like gone. So the next thing to fix is the headache, okay? And I went up and treated the cervical spine and musculoskeletal approach, basically the supine cervical practicum, 40 and 94, torn and broken of the ligaments, inflammation in the disc, the joint capsule, scarring in the nerve, scarring, inflammation in the nerve, nothing worked. So the supine cervical and musculoskeletal approach didn't do anything. So it occurred to me, yeah, that's not what it is. So she had this mold thing going on, right? And the headache was very diffuse. It was across the front of her skull. And I couldn't find a structure that would change it. So I ran mold to 23 in the spinal fluid. 288 is the frequency from the advanced to the spinal fluid. If you haven't had the advanced yet, well, you'll get it this year or whenever you take it. 288 is the CSF. And that took her headache down, like from a 6 or a 7 down to a 3, 2. Then I did spinal cord, 10, 90 the forebrain, and that took it down some more. But then she still had, I don't know, she still had something. So for some reason, I took the contact that was on, I had one contact on her neck and the other one on her forehead, took that contact and put it down on her sinuses, on the front of her face, under her xiphoid, is that the right word? and then up on the forehead, and ran 23 mold in the frontal sinus and the paranasal sinus, 25 and 75. And the headache was completely gone, and she was pain-free in 20 minutes. So when you come to the advanced in Phoenix this year or Phoenix next year, we'll talk about mold more and more and more. Mold is inflammatory. Black mold is a neurotoxin. So when you have black mold 23 and 109, the vagus gets paralyzed. It doesn't work well. So they will have loss of palate elevation, they'll have impaired digestion, they'll have gastroparesis. When the mold inhabits or colonizes the gallbladder, the bile duct, the upper portion of the bowel, you get gastroparesis, you get abdominal pain, you have gallbladder dysfunction, poor digestion, all this stuff. And when we treat for what we would normally think of as being responsible for that, we doesn't work pretty much, and gives you a little bit of relief, but not much. And this frequency for mold, now it's also the frequency for typhoid, which doesn't make any sense at all, but it seems to work really well for mold. It just helps a tremendous amount. This is the first time ever I have run 23 and 288, the spinal fluid, mold in the spinal fluid. How a neurotoxic mold would get into the spinal fluid, I can't even approximate, can't even guess. And how or what mold would do in the spinal cord, brain, the sinuses make sense, but the spinal cord and the forebrain, not so much. Sinuses, the mold in the environment gets in and colonizes the sinuses. These are the frontal and the paranasal. They're more susceptible to it than the ethmoid, but I guess all three of them could be that way. The neat thing was getting rid of her headache. So when you do the advance, the thing to think about is that mold is inflammatory, and 288 is the spinal fluid. So you kind of take this from the specific to the general and think about where you can apply the frequencies for mold. Okay, the next one. This was a patient who's 29 years old. He has a 9-year history of Lyme disease. So he had a tick bite. He's in college. He's been through traditional, non-traditional treatment for acute and then chronic Lyme disease. Now, the Lyme is quote-unquote cured. What remains is his bilateral anterior leg pain and fatigue. Those are his major complaints. So the anterior leg pain, I was sure it was 81 and 10. Remember the first case we did today? Oh yeah, your legs are tight. Well, his legs didn't actually feel that tight, but I was convinced it was 81 and 10 because Lyme can settle in the spinal cord. I've had patients where it did that, and it was actually apparently in specific tracts of the spinal cord. So I did 81 and 10 neck to feet, and actually didn't do much. It didn't work. So he had been treated by an FSM practitioner, and he thought that they had treated him for trigger points. And so I treated him for trigger points from his groin to his legs. And yet, nope. That didn't do anything because honestly, there were no trigger points in the muscles. There's no trigger points there. Muscles, there was no increase in tone. So 81 and 10 didn't do anything. There was no trigger points. That didn't do anything. So that, well, now he traced down the leg from the groin bilaterally down to his feet. And I thought, well, the only thing he's tracing with his hand is the femoral nerve. Now, he had Lyme, right? Lyme would create inflammation in the lymphatics, and the femoral nerve is hard to traumatize. I mean, it's not a thing we create trauma for, like we do the sciatic nerve with the discs. Femoral nerve plexus is pretty well protected if you're a male and you have the femoral nerve cranky, you've got some other things that have been compromised or traumatized as well. So, but the thing with Lyme disease is that because it's an infection, and because when you treat it, there's going to be fairly huge inflammatory response as you kill off the bacteria, as you have the war of the immune system in the lymphatics. I thought, well, you have all these inguinal lymph nodes, and when you look at the anatomy, you have the inguinal lymph nodes, and they are right smack on top of the femoral plexus where it exits at the groin. So I did 40 and 396. Now, he was on a fair amount of medication, so his pain he rated as a 4 or a 5, but he was on gabapentin and a bunch of other stuff. And I treated low back to feet, and it didn't do much. And he said, no, it hurts right here. And he pointed at his groin. So I put the towels up on his groin and then ran. So it was one towel that was covering both of his legs. And I just sort of stuffed them up under his underwear into the groin, over the inguinal lymph nodes and the outflow of the femoral nerve, down to his feet, ran 40 and 396, and that did it. I did treat low back to feet. His leg pain went back up, so I treated groin to feet first. Then I said, oh, we'll treat the whole nerve. Did low back to feet. The leg pain went back up. Put the contacts back from the groin, went back to 40 and 396, and the leg pain went back down again to 0. So the model I had with it after that was the inguinal lymph nodes are inflamed from the Lyme adventures and irritate the femoral nerve where it passes close to the inguinal lymph nodes. So I did 40 with lymph and 55 for the Lyme, the spirochete with the lymph, and then finished with 14 and 396. And when he left, he was pretty stoned, which is kind of fun. But his pain was 0. He had no leg pain, which is like, what was that, 9 years? Yeah, 9 years. So that was pretty amazing. And he had to go to work. So I programmed a custom care with basically that protocol and left it with him and his dad. And we'll see how he does. So that was pretty fun. It's just like, for us, nerve pain is easy. For me, the biggest challenge I had was getting this 81 and 10 tight leg model for leg pain success out of my head. With him, that isn't what was wrong. With him, what was wrong was inflammation in lymphatics that caused inflammation in the femoral nerve. It wasn't coming from his back, so when I moved the contacts to his low back and then down to his feet, his leg pain went back up. And when I went back to the groin, moved the towel again to the front and went down to his feet, his pain went back down to again to a 0. I suspect he's going to do pretty well with just the one treatment before he picked up his custom care. He said he slept better that night for the first time in a really long time. The pain relief lasted maybe 5 or 6 hours, but he did sleep better, which suggested the pain was still down. So the last patient, this is the one I could not get I couldn't get the email to copy. This is a patient from July of last year. Her history was that she had a spinal cord tumor when she was 1.5. They kind of missed it. They diagnosed it with cerebellar ataxia. She had surgery when she was 2.5. It was a glioblastoma. Surgery was from T1 to T8, I think. And she was fine for about a year, and then the symptoms came back, so they did radiation when she was 3.5 years. So from the age of 3.5, so she is now, how old is she? 32. So number one, she didn't die. The cancer did not come back. So that by itself is miraculous. So she's 32 years old. She's better than three-quarters of the way through a bachelor's degree. And she hasn't been out of pain since she was 4. She has a very, it's not even ataxic. It's the kind of gait you see in a patient with a spinal cord injury. So glute medius weakness, spasticity, muscle weakness, some lack of tone in her trunk muscles. So when I treated her the first time back in July, she's the one where I had to do 40 and 10 to get the body pain down. And then she was incredibly spastic in her legs. It was just pretty awful. So 81 and 10 to get rid of spasticity. On her, we had to run 2 precision cares, both from neck to feet, both in the same towels, one with 40 and 10 to take the pain down, one with 81 and 10 to take the spasticity down. That took about an hour. And from the back and the abdomen, there was a unit that was just literally running 40 and 89. So when you've had your pain level at a 7 for, 29 years? Virtually your entire adult life. And you get the pain down to a 0, who are you? So there's that identity crisis thing. But there's also the fact that the midbrain changes. When the midbrain is under that kind of assault from pain, it tones down all the parasympathetic activities. It tones down all of the vagal and restorative activities, and it jacks up all of the survival stress hormones and agitation and the brain fog and the memory difficulties and all of the things that happen when you're under an incredible amount of stress. So we ran one machine with 40 and 89 for probably an hour and a half, 2 hours, while this other was going on. And then I had a 4th machine from a spine to a front, treating radiation, 54 and 10, the spinal cord, 43 is the dura, 396 is the nerve. So radiation is the gift that keeps on giving. When you want to get rid of radiation, you have to run 54, and 40 actually should be added in here on the channel A, along with the spinal cord 2, addressed to the spinal cord, the dura, and the nerve, and then scarring and the nerve, the dura, and the spinal cord. So that was July. Now through the summer and into the fall, she's starting to exercise more. Her pain is staying down better more. She had a disadvantage in that she was on Cymbalta, and it took her a good 4 months to get off of that drug. That was horrible. It was just flat horrible. They finally put her on Wellbutrin, which has a little bit of a dopamine effect, and that helped her with the withdrawal. When she got off of Cymbalta, they were able to put her on Wellbutrin, and that a low dose of Wellbutrin, and she's doing very well on that. Pain meds are down, everything else is down. Baclofen is down, everything. She hasn't used her spinal cord stimulant since July. So I saw her again this January, and she's now, while between July and January, she's getting sick a lot. Her immune system is just thrashed. And that is, once again, this central sensitization business. If you keep your immune system on high alert for 29 out of 32 years, at some point it just gets exhausted. So she was susceptible to every random wandering virus and got sick a lot. She got bronchitis a couple of times. She got sinus infections. And I really fussed at her about increasing her vitamin D, increasing vitamin C, and just giving herself some slack, just rest. So she's a 32-year-old with all the desires of a 32-year-old to lead a normal life. So when I saw her in January, then it was time to treat scar tissue more. She is now exercising 3 to 4 times a week, trying to recondition the muscles that have been weak. If your muscles are spastic from a spinal cord injury, they don't move. They're just spastic. They're just tight. When you get them to relax, they're weak. So the muscles had to be reconditioned. Now that she's moving more, the scar tissue between the dura 443, the nerve 396, and the spinal cord, that turned up more. So treated the scarring in the dura, treated not just 40 in the midbrain, but the whole subacute midbrain protocol from the auto care. 40 and 94 to quiet down the reticular activating system, and then increase secretions in the vagus to improve her digestion. Her digestion was still a concern, and brain fog was a concern. Her higher centers were just not cutting it. Now, this is because, and we'll do more of this at the Advance this year. If you haven't signed up for it, I strongly encourage it. I wrote the slides for my workshop yesterday, and it's the big picture. It's connecting how the forebrain, the midbrain, and all the stress centers in the brain connect, and what effect that has on cognition, which is upstream from the midbrain, and digestive function and body function, which is downstream from the stress centers in the brain. So I treated brain fog. And then the other thing I did on her was, TTH, that the energetic causes of kind of chronic pain issues, things that go wrong when you kind of roll from one disaster to the other. I ran that on her, and that had quite a profound effect. So that is now on her unit, and she says she likes that a lot. I put brain fog on her custom care. She actually has 2 custom cares. And I put chronic midbrain to try and quiet down the midbrain stress brain centers, and that will help her forebrain to work better. So if we quiet the midbrain down, like if it's not screaming at her, then her brain will work better. Why would you want to remember anything if a tiger's chasing you through the woods? Well, if you can put the tiger to sleep, then the forebrain will work better, and she'll do better in school. If you can put the tiger to sleep, then her digestion will work better, and her vagus will work better, and everything will work better. So the key to all of this recovery was getting rid of the scar tissue so she could exercise, and then get rid of, and then quiet down the midbrain. So this is the part where I wanted to, are they going to be able to see anything that's on my screen? Or does it have to be a slide?
If you do the, if you escape out and then do maybe the switch. Actually, I think if you just escape out, we can see your screen.
Okay, so you guys are going to see my screen. I'm going to try and do this quickly so that you can't see her email address. How do I do that? I need to get her the text up. I couldn't copy the text, but I want you to read it. I want you to see, I wanted you to see what she had to say. There's Kevin.
I'm not exactly sure how
Where'd you go?
show part.
So
I'm not sure how to only show part.
All right. Come on. How do I get just this up?
Yeah, scroll. There you go.
Okay. I don't want them to see this part. How do I do that?
It's either all or nothing.
All right. Well, just ignore this.
I can see if I can go in post-production.
There you go. There we go. I just need to get rid of. Okay. So this is her reply after the January. The unraveling process continues with the spasticity, and I'm amazed and still longing all at the same time. She's been in a big hurry. She doesn't understand what an amazing process it is to be pain-free and have range of motion for the first time in her life. So she wanted it all in one time. So that was just a matter of talking her down out of the tree on a pretty regular basis. Human condition, right? She's so smart. Searching for more and better. My okay days have gone way up, and at times I will start the day either bad or okay and then end it good. Spending way more time out in the living room, interacting, going outside to read. And this is a matter of getting 40 and 89 down and getting her body pain down. She's not in the cave. She's not hiding out. She's not in pain. There is no tiger. I'm able to be comfortable in many different locations now, which makes life in general a lot easier. Bad days are fewer and easier to get through than in the past with the midbrain help. So that's that midbrain, chronic midbrain thing. And energy clearing, which is what I call the TTH protocol. New modes are very helpful on these days. I don't go so far to down the rabbit hole mentally on the bad days. And in general, just try to rest and use the modes as much as I can. So she's probably using these two custom cares 4 or 5 hours a day. The good days are getting even better. My mornings are getting easier. And on good days, I feel like my old self who's happy to see the mornings and watch the day start. She's working out more. This will be the 4th week. I know it doesn't sound like much. Oh, honey, it sounds like a lot. It's a huge improvement. She wants to lose weight, whatever. And she's been using a slow weightlifting method. I had to talk to her about eccentric contractions with light weights, decrease the weights and sets, but she's just finally just doing well physically. School has started. She has started the 2nd week. So far, really enjoying both classes, concerned about this major project, blah, blah, blah. And hope you are, my life may have changed, but I no longer hate everything I see about myself. I was wondering if you had a, yeah. So that's her story. And it's quite a, I don't know, small miracle, right? It's like, how do you do that with a patient? Let me get this back to the very beginning. So these are small miracles for us because honestly, her case was just not that hard. It was a matter of 40 and 10 to get the body pain down, 81 and 10 to get rid of the spasticity, 13 and 443, 13 and 10 to improve her range of motion, and 40 and 89 to create this small miracle. But this patient has had her life changed forever. I mean, she's not the same person she was 7 months ago. So this is miracles for patients. It's what we do, and it's why you're doing what you do. And that's about it. Glad you made it. Sorry, this webinar is a little bit sketchier than they usually are, but I've been on the road for about 2 weeks and I put it together pretty quickly. This February 22nd, 23rd, 24th, 25th, Friday, Saturday, Sunday, Monday, we are in Phoenix for a core seminar at the Crown Plaza. You'll find it on the website. I didn't have time to put it on the webinar. Then Tuesday and Wednesday is the sports seminar, the 2-day sports intensive with Kim Pittis. The reviews on this class have been absolutely fabulous. And if you treat either professional or amateur athletes or just have an interest in sports medicine, Kim's perspectives and the protocols she shares are just extraordinary. It's funny for me to see, and the reviews for the class have been great. Then Jay Shaw is on Thursday. He's from NIH. He will be talking about myofascial pain, but he also talks about central sensitization, spinal cord sensitization, and the mechanisms of central pain amplification and myofascial trigger points. So if you've never heard Jay Shaw speak, we are not allowed to videotape this. We are not allowed to audio tape it, and he doesn't give us the slides. So this is one of those things where you just got to be there. And if there was ever a time when I would encourage you to come Jay Shaw's it. The class is inexpensive. It's a one-time event. He hasn't been with us for about 4 or 5 years, and he's not likely to be with us again for another 4 or 5 years. He's $249 for the Jay Shaw one-day course, and it's well worth it. It's kind of, you can take notes, you can take pictures, you can do whatever you want, but NIH will not allow him to share his slides or notes. He has given us a packet of about 10 published papers that are the foundation for his talk, and those will be part of your handouts. The advanced seminar has got a faculty that I'm just absolutely excited about. You can check the schedule on the website. It is, can I bring the schedule up? There's a Word diagram. Okay. There's a Word document. See if I can find it. Hello. Oh, maybe not. Oh, I have to get over here. Come on. We have David Musnick talking about head injuries. Oh, really? I just finished my workshop on the brain connection, and it is I've never done this before, but it's basically putting everything together that we've seen in the brain in the last 20 years. Really? Come on. There we go. So the core seminars are 23rd, 24th, 25th. Kim Pettis is the 27th and 25th, 26th. Kim Pettis is 27th, 28th. Jay Shaw. Friday, I've got my section, and from 9 to 10 for the group that has already taken the core seminar, we have that 3-hour block from 9 to 12 where you don't have to listen to me because you already listened to me. You can go to the workshops that morning. The first hour of that is going to be on sleep apnea from Michelle Toon and Phil Dukes from Itamar. They make the WatchPat, which is an in-home sleep test device. And the biggest problem with sleep studies is they're just obnoxious. You're sleeping in a lab, you've got goo stuck on you, they're just horrible. And so I don't order as many as I should. But this in-home sleep study has just completely changed the game. It's a watch device that you wear that checks oxygen saturation and pulse. It also has a microphone that kind of glues to your chest that tests for sound and your position. It's a GPS. So are you on your side, your back, your stomach, your other side? And they will give out 5 of them overnight for sleep studies, and the next day they'll go through the results so 5 of you will be able to see who it is has sleep apnea. Sleep apnea is one of my pet peeves aside from anything else. This WatchPat device diagnosed me with sleep apnea this summer, and these guys saved my life. I'm more rested and healthier than I have been in 20 years. It's absolutely amazing. So sleep apnea is, we're sharing that with you at this advanced course because pretty much it doesn't matter what else you have. Sleep apnea is what you will die of. And sleep apnea will get in the way of everything else you do to get a patient healthy. So then Kim is going to do physical medicine strategies and a practicum from 10:30 to 12. We're going to have, instead of banquets at night, I decided to try lunch and awards in the daytime so we don't have to go wandering off into the city. And then you can go out at night and have a good time and do whatever you want. So we're going to have our banquets at lunchtime instead of at night. David Musnick from 2 to 3:30. They're 90-minute workshops. Concussion and TBI. This is a brilliant workshop. I saw him presented at IFM. Rob DiMartino has the business end of FSM down to a fine science, and he's going to do an hour and a half on that, leveraging and integrating FSM into your practice to grow your practice. And I know he's a chiropractor, but his information is applicable to every clinical specialty. And then I've got the advanced in the morning. We have another hour of sleep apnea, and then Paris Carbot is going to go from 10:30 to 12, integrating an FSM and a functional medicine in complex patients. This is a wonderful presentation. She's been working on it for months. It's well researched, well supported. It's just brilliant. And then our group lunch will be FSM Award for published papers. Jody Adams has published a paper, and she has $1,000 cash prize to the author of any peer-reviewed paper, and Jody is the recipient of this award this year. I'd love to make a surprise, but she's the one. Visceral medicine track from 2 to 3:30 is Dave O. is changing the terrain for complex patients with FSM. And then Jody Adams is going to do diagnosing and treating upper cervical instability. Always important, not always easy. So she is going to talk about spinal stabilization. Sometimes you win, sometimes you lose, but it's always important. And then my workshop is from 4 to 5:30. FSM, this has been the year of the brain and body. Integrating how do you treat and connect and manipulate and change the connection between the cerebellum, the sensory cortex, the vagus, the motor cortex, the pons, and the body. We have case reports in all of those, and this practicum makes your brain hurt, but it's the beginning of the next probably 5 years of advancements in FSM treatment. So that's the advance this year. I know it made us run over time, but it's pretty fun. Hope you sign up. I'll see you in February at the advanced, I hope. And thanks for joining us for this webinar. And do we have any questions?
The only question we had was somebody was just wondering if these were single treatment cases.
Oh, they're not single treatment cases. The girl, the spinal cord patient, the rest of them actually were all single, actually 1 or 2 treatments. They pretty much don't take that long. Whether or not you need something as a second or third or fourth treatment and what you need as follow-up is really going to depend on what your body does with the changes you made. So the second treatment, you treat what you find. So my case reports were all single treatment, but if they were in a practice and they were coming back, they'd come back to see you in 3 days and you treat whatever was left. So that's a good point. Do good things, do miracles, and I'll see you at the advanced, or I'll see you next month. Bye.